Look, it's a real privilege to come this evening and talk to you about something that I'm really very passionate about, which, as Graham said, is the role of exercise in the treatment of cancer, specifically prostate cancer, as well as the management of the side effects of the treatments of cancer. I guess very quickly a bit more of a background. We operate what we call an exercise clinic at our university campus in Strathfield, where we cater for predominantly prostate cancer patients. And we've operated for the past 4 years, and we have an exercise clinic, and we have relationships with local hospitals, and we get referrals through them. So I guess in addition to this overview, I'm going to give you a bit of an insight into exactly what that's all about. It may be something that you haven't heard of previously, but there are programs out there, and I guess part of what I hope to accomplish tonight is to plant a little seed in your mind that grows and kind of convinces you that exercise should really be an integral part of your journey with prostate cancer or recovery from prostate cancer. So I want to talk about cancer and treatment-related outcomes very briefly. I'm going to spend some time talking about the evidence behind the importance of exercise. It's one thing to just say you should exercise because it's the right thing to do, but there's actually a lot of evidence to support those sorts of claims. I want to talk about exercise in the elderly. It's quite a unique population. I'm going to talk about evidence again, but this time for a very specific type of exercise called resistance training. Some of you may have heard that term before, maybe not. Strength training, weightlifting, resistance training, and I'll give some examples of that as well. And then I'll finish talking about what we do in our clinic in Strathfield. So I'm not going to spend a lot of time on this because it's something you're all familiar with. These are some of the common treatments for men dealing with prostate cancer. Most significantly, at least for most of the patients that we see, hormone therapy is very, very common, and probably many of you have had experience with that, and then of course some of those other ones as well. The point is that, and again you would be well aware of these because these are things you've all experienced. These are the typical outcomes for men undergoing these kinds of treatments, and again particularly this hormone therapy, the androgen deprivation therapy. The androgen deprivation therapy is quite effective in slowing the rate of growth of prostate cancer cells, which is a fantastic thing, of course, but unfortunately it has some of these quite significant side effects. And they relate to losing muscle mass, increasing in fat mass, accelerated loss in bone mineral density, and then related to those, a loss in what we call functional capacity, your ability to do things, what we call activities of daily living, getting around the house, jobs, whatnot. So these are all affected, and then we have some other common patient outcomes related to cancer and the cancer treatment as well. From our perspective, as what we call exercise physiologists, we're interested in using exercise as a therapy to try and overcome some of these. We're worried about these particular outcomes, these particular side effects, because they increase fall and fracture risk. You're not as strong, your bones aren't as strong. That's a real problem. You have a loss of functional capacity, or many experience a loss of functional capacity. That's a problem as well, and it's a problem we believe you can overcome with the right kind of exercise advice. And then we have increased risk of certain metabolic diseases, cardiovascular risk, diabetes, and some of those. So these are the things that we're interested in addressing with our exercise programs. And then the other one that is related to this as well, it's this idea of fatigue and cancer-related fatigue. It's actually one of the most frequently reported side effects of any cancer treatments, and it's obviously very, very distressing side effect or consequence of cancer to have to deal with. So I want to talk about some of those things and how we use exercise to try and address some of those problems. In terms of cancer-related fatigue, and many patients that I speak with, especially the first time we meet, they're concerned that they need to conserve energy because they're experiencing cancer-related fatigue. They don't feel like doing anything. And when you get into a situation like that, you actually have to do the exact opposite of what you feel like doing, which is you actually have to get up and do something. If you avoid doing things, and you have to manage it carefully, but if you avoid doing too many things, you get into what we call a vicious cycle. So you get tired, you feel like you need to rest. When you rest too long, you start to decondition. You start to get weaker, your cardiorespiratory fitness goes down, and you're able to do less. And when you do less and you decondition, you get tired more easily, and then you want to rest more. So it's a vicious cycle that we really try and avoid, and we can interrupt that or intervene with exercise. Even though you don't feel like it, it's actually the thing that you should be doing, should be prioritizing most. And this vicious cycle, the end point of the very worst case scenarios that cancer, cachexia, which you may be familiar with, extreme deconditioning that we get in elderly patients. So in terms of cancer-related fatigue, in terms of some of the research about it, it's actually quite similar to other centrally mediated fatigue conditions. And what I mean by that is other fatigue conditions that originate, at least in part, in the brain. So they're controlled in the brain, and therefore they're similar to things like chronic fatigue syndrome, and they're similar to things like major depression. Now, in terms of the research for the role of exercise, originally the research was related to major depression, chronic fatigue syndrome, but now because we know that there's so many similarities with cancer-related fatigue, we now have some building evidence of the role of exercise in overcoming cancer-related fatigue. So here is a collection of studies. Don't worry about the small numbers in the writing. There's a main point to it. This is a collection. Each one of these rows here is a study that has looked at the efficacy of an exercise intervention in treating cancer-related fatigue. And what this collection of studies does is it summarizes the main, or gets the average effect of all the studies that have been done in the area. And the main take-home point there is that exercise reduces cancer-related fatigue. So when I first meet with patients, and they often express concern that taking on something that seems quite daunting, like doing resistance training, is going to make them feel more tired, it only takes them about 1 or 2 weeks to realize that the exact opposite is true. Okay? And there are a number of studies that have been done to support that. Okay, so in terms of the research in this area of cancer and exercise, an area I'm quite interested in, since the first report linking cancer and exercise, kind of demonstrating that there's some relationship between cancer and exercise, only as recently as 1922, between then and 2009, there were only a few hundred publications on the topic. Between 2009 and now, there are now thousands of publications on the topic. So it's a really, really exciting area from my perspective as a researcher and someone who works as a clinical exercise physiologist, because there's just this burgeoning amount of information and amount of data coming out of studies, some really good studies. And I'll take you through some of those today. So there's an increasing number of high-quality studies, randomized controlled trials you're probably familiar with, you might be familiar with, where you take 2 groups of people and you randomize them. They're a really high-quality kind of study, and we're seeing a huge increase in the number of randomized controlled trials in the area of exercise and cancer. So that's good for 2 reasons, because we're getting good quality data now, and it also means that funding bodies have identified that there's something worthwhile funding in this area. And that's important for us as well, and exciting for us as well. And when you have lots of randomized control studies, you eventually have the ability to do what are called meta-analyses, where you take the findings from all those studies and you get an average finding, which is quite powerful as well. So in terms of exercise and particular outcomes, here are some of the results of various meta-analyses, and we have a number here. It's called a weighted mean effect size, and it's just a statistical way of assessing how big an effect there was. So in terms of cardiovascular outcomes, these are all for cancer patients being treated with exercise. Cardiovascular outcomes for activity levels, for the number of days in hospital, in other words, fewer days in hospital, decrease in reporting of symptoms and side effects, and fitness, and there's what those numbers mean. So I guess the take-home message there, without getting lost in the numbers, is that this evidence is starting to build, and we're starting to see more and more of it. And there's now good evidence for some of these kinds of outcomes, specifically for cancer patients. Okay. Again, this slide here, don't worry about the small detail. What it is a framework of the current state of research in exercise and cancer. And the little blocks there kind of show us that we've got some good research coming out of breast cancer, some good research coming out of colorectal cancer. But really what it is, it's a roadmap for us to look at and go, here's the evidence that we have so far, but here are all the various holes that still need to be done. So there's still a lot of work to be done. And again, the take-home message here is that up at this point in time, we have strong evidence that exercise limits the treatment side effects. And the very exciting thing for us is we're now starting to see studies and evidence that, that exercise can actually modulate the disease itself. Okay, what I mean by that is exercise can directly affect the way cancer cells behave, the way they grow. And that's the new area of research for us, researching exercise and cancer. And that's really exciting. That's, those sorts of studies are only starting to come out in the last 2 or 3 years. And I'm going to give you some examples of those. So for the first time, we're starting to think that exercise may directly affect the way the cancer cells operate. And here's one theory that I thought would be interesting to point out. And it's the theory that our muscles are actually an important organ. Our muscles actually release chemical hormones. They like hormones, and they're called myokines. Okay? Myo simply means muscle. So this is a very recent discovery that our muscles, we previously thought were only much use for moving us around. They're actually a pretty important endocrine organ that release their own hormones. So we have this emerging hypothesis that muscle is actually really important to regulate your whole body inflammation. And this is related to the idea that probably many chronic diseases have something to do with a state of chronic inflammation. So the idea is that metabolic diseases, cardiovascular, diabetes, diseases of the central nervous system, and a number of cancers, let's say the situation is made worse when there's a state of inflammation. And these myokines are important in regulating how much inflammation you have. So it turns out that having muscle is actually quite important from an endocrine hormonal perspective, as well as a perspective of the ability to do things. So this is quite an interesting area for us as well. Here is a fantastic study that I wanted to talk to you about, and this is one of those studies that shows exercise interacting directly with cancer cells themselves. And what we have here in this study is 2 groups of mice, and both of them have had a prostate cancer tumor introduced to them. And what they did then is they make one group of mice a sedentary control group, And they get the other group of mice to do exercise training. They have little treadmills, put them on a treadmill and get them to train. And what they're measuring here is they're measuring how much oxygen is being delivered to the cancer, the prostate cancer tumor itself. And what they found is that the group of mice who do exercise training, there's their oxygen over there, both graphs are telling a similar thing. Their tumors receive much more oxygen. And that's a good thing for preventing a prostate cancer tumor from becoming very aggressive and wanting to move to other parts of the body. So the exercise actually, it kind of subdued the tumor and made it behave a little bit better. And the reason is related to the little blood vessels that develop when you exercise. You grow new blood vessels, and when these mice exercised, there was an increase in microvascularity. That's just the small blood vessels that surround the tumor, which reduced the tumor hypoxia, in other words, delivered more oxygen to the tumor, which led to a less aggressive type of tumor in the mice. So it's really exciting for us because we're starting to now see these kinds of studies emerging, showing that exercise directly interacts with cancer. Here's another one. This is quite a unique study as well. What we have here is you have two conditions, a resting condition and an exercise condition. Again, it's prostate cancer cells. This time, though, they're growing them in petri dishes. So it's not in an animal. They're growing tumors. And what they did, they actually got humans to exercise really intensely. And once they'd exercised really intensely, they extracted some of their blood, and they called that exercising blood. So the idea is that there are some factors in your blood, or factors that your body produces after you've done some exercise, that might interact with the cancer cells. And then they added the exercising blood to the prostate cancer cells, and then they added some resting blood to the exercise cancer cells. And of course they measured how well the cells grew. And you can kind of see it there. Cell proliferation is just a term for how cells grow and differentiate. And the exercise, when the exercise blood was introduced, the cells didn't grow as well. So we made the exercise made the environment less conducive for the cells to grow. Again, really exciting evidence for us. So the exercise, and this was an acute bout of exercise, so one bout of exercise, somehow, we're not sure exactly, but caused an inhibitory effect on the prostate cancer cells. In this experiment, there was a 31% reduction in the cancer cell growth. Okay. So it's not to say that we can make the leap and say if you go out for a run, your prostate cancer tumor is going to disappear. But it's really exciting to see some biological evidence coming now that exercise can directly affect cancer cells. Okay, so exercise is a valuable adjunctive therapy in the treatment of cancer. You might be wondering what kind of exercise can you do. If you feel like that, you mightn't feel like you are up for much exercise. But I want to tell you that what you ought to be doing, and I hope I can convince you by the end, is resistance exercise. This, I love this picture. This gentleman's name is Mick, and he's been exercising with us for 4 years, and he comes twice a week for 50 weeks of the year for 4 years, and he's fantastic. So Mick had a radical prostatectomy about 20 years ago, but then his PSA started to climb again, and he's been on, you familiar with Leuquin? He's been on Leuquin for 5 years. Okay, so for the full duration that he's been exercising, he's been on Leuquin. And he loves it. He loves exercise. Okay. So just as I guess a way of kind of demonstrating what I mean by resistance training. Resistance training is moving heavy weights, lifting weights in a gym-like setting. Ours is set up to be a clinic. It's not a commercial gym, and we have only We have groups coming in for 1 hour sessions, and they're only prostate cancer. We have only prostate cancer groups. Okay, so that's an example there, and that's an example there, and there. And Mick again, doing pull-ups. He can do lots of pull-ups, but he's been practicing for a long time. Okay, all right. So I guess we've probably always known that being strong is important. Ironically though, the first study to kind of demonstrate that was only as recently as 1999. And what they did in this study was part of a larger study, and they had about 6,000 men, and in their mid-50s they took some measurements, and then they did a follow-up about 30 years later when those same men were in their 80s. So they did collected some data there, and then again 30 years later. And what they did was they assessed what we call activities of daily living: walking, climbing stairs, sitting up from a chair, picking up things, getting dressed. They took some of these measurements. The main thing they did was they measured their grip strength. So they measured their grip strength when they were in their 50s as a surrogate for whole body strength. We have much better measurements than that, but it's a simple measurement that you can do on 6,000 men. And they measured their strength at their mid-50s, and then they broke the group up into those who had the strongest hand grip, those who were the middle, and then the third of the group who were the weakest. And then 30 years later, they had a look at their ability to do things. This is their self-reporting limitations, so self-reported difficulty in doing activities of daily living. And look at the pattern there, it's the same for all these measurements. In the light bar there, that's the highest grip strength group from 30 years previously, and then the middle, and then the lowest grip strength. So the lowest grip strength group had the most difficulty 30 years later doing things, getting dressed, showering, eating, and whatnot. So in this demonstration here, grip strength or strength was a really important predictor of how well you'd be able to do things 30 years later. So we've kind of always known that being strong is important, that was officially the first study to show us that. Okay, so being strong is really important. It's important because muscles are an important endocrine organ, and it's important for your ability to do things as well. So we're interested then, as researchers in this area, how do muscles grow? And the first thing we started to look at, well, how do young muscles grow? And in this picture over here, you have a piece of muscle under a microscope. And when you look at a piece of muscle under a microscope, you see these little black dots. And they're actually sitting there. We've got muscle cells, which are long and thin, and they're running from left to right on your screen there. And when you look at them, we've got these little black dots on the outside. And initially, we thought those just must be mitochondria or other parts of the cell. And then we worked out that they're actually a very, very specialized cell called satellite cells. And satellite cells are what are called undifferentiated cells. They don't have a job yet. And they're kind of just waiting in the wings. And if you give them the right stimulus, they'll become whatever you want them to become. And that was quite an amazing discovery as well. So young muscle is peppered with lots of satellite cells. You give it the right stimulus, and what happens is those satellite cells proliferate. In other words, they start to grow and they differentiate, and then they actually integrate into the muscle cell. This is a muscle cell in cross-section. And once they integrate into a muscle cell, they donate their nuclei, and then that muscle cell now has the capacity to get bigger. And that's how cells get bigger. So this is how young cells work. So the next question that's an obvious one for us is, well, how do old cells, how do old muscles behave? So satellite cells are really important for young muscle. What about old muscle? And one of the first studies to look at that looked at how they measured satellite cell proliferation, and they measured the extent of sarcopenia, which is age-related muscle loss. and they took 14 men, 65 to 85 years old, and they got them to do resistance training, and reasonably intense resistance training. So they're doing 4 sets at 10 to 15 repetitions at quite a high percentage of their maximal strength. So it's quite intense exercise. They don't start them on that, they start them progressively, but it ends up being quite intense, and they do it for 3 days a week for 12 weeks, and they measured a couple of different things, and the important things here are that in both the main types of muscle fibers, in the dark bars there represents an increase in the number of satellite cells. So the muscles got stronger by 30% over 12 weeks, and most astonishingly, the number of satellite cells to the number of muscle fibers, that ratio increased 76%. So even in very old muscle, given the right stimulus, you will rapidly get an increase in satellite cells. And once you have an increase in satellite cells, you now have the capacity to have those cells move into the muscle itself, and the muscle gets bigger and stronger. So muscle tissue in the elderly remains capable of increasing satellite cell proliferation and therefore hypertrophy, which means that muscles can get bigger and stronger. Okay, you might be wondering how safe is resistance training in elderly patients. We have a number of studies that we can look to kind of answer that question. So this collection of studies here is a collection of studies that have done quite heavy resistance training in elderly groups of patients. And don't worry about all the little numbers, I'll point out the important ones. So the average age across all the studies there is 71. They're doing quite a lot of resistance training, so anywhere up to 12 weeks, up to 1 RM is your repetition maximum. So if the maximum amount you can lift is 100 kilograms, then 80 kilograms would be your 80% RM. Okay, so it's quite intense exercise, and there's the average age. There's the other important number. This is the average strength increase is 74%. Dropouts were low. Serious training injuries were low as well. So resistance training based on these studies is very, very effective and very, very safe. And I'd like to point out this one study here. Have a look at the average age of the subjects in that study there. It's Maria Federoni Singh. She's at the University of Sydney. Yeah, she's, she was quite brave, and people said, you can't do that. And she did it. She did it effectively. They just about doubled their strength. They more than doubled their strength there. 174. And their average age was 90 years old. Okay, so it's never too late. Okay. This is another study, one of Maria Federoni Singh's. I'll go through it quickly. So again, just demonstrating a type of study where the average age is quite old. There's the single oldest person, 98. Again, using resistance training as the therapy, and they did it for 10 weeks. This time they were actually interested in looking at what happens inside the muscle. So again, we have a picture of a piece of muscle under a microscope, and that's before you do any exercise. Left to right are your muscle cells running like that. And post-training, this is what happens, and that's a completely normal thing. It happens in young people and it happens in old people. It does take a little bit longer to recover. It's a normal part of the process of muscles getting bigger. It takes a bit longer to recover. But the point there is that that damage is normal and necessary for remodeling. It is worse than young muscle, but what that means to us is we just take a different set of precautions when prescribing exercise to someone who's 98 years old. It doesn't mean we don't prescribe exercise, it means we do it in a slightly different way. And of course the important thing is the muscle still adapts. Okay. I'd like to just go through some of the studies. specifically looking at using resistance training in prostate cancer. And I've divided them up into three main areas that we're interested in measuring. So these are studies that have looked at either body composition outcomes. Remember, body composition, we're not that interested in how someone looks. We're interested in their muscle, their bone, and their fat, for all those reasons I mentioned earlier. We're looking at studies that measured functional performance, and we're looking at studies that did some sort of measure of quality of life, which is usually a questionnaire type of outcome. So we have 12 randomized controlled trials that met the criteria. In other words, they had patients who were on androgen deprivation therapy and or radiotherapy, and they undertook some resistance training, a resistance training program. And we'll look at the results of those studies. So again, this is a collection of those studies that have measured those things. What I'm pointing out here are the studies that have looked at body composition in particular. And we've got the main outcomes over here for bone, muscle, and fat. The average age across all these studies was 68, and those are the outcomes. So the average muscle increase was 5%, okay, which is quite significant given that most studies are only 12 weeks in duration or less. The average fat reduced but wasn't significant. We're not too worried about that because that's still clinically irrelevant for us, because if your fat hasn't increased, if it stayed the same, we were expecting it to increase because of the effect of androgen deprivation therapy. Most men start to put on some fat mass. So the fact that it stayed the same is kind of a good outcome as well. But obviously the interesting one there is that the muscle increased 5%. So hang on, are these studies saying that muscle mass increases in testosterone-deprived males? Of course, that's what androgen deprivation therapy is. They block either the effects of testosterone or reduce the body's ability to produce testosterone. And probably, as most of us know, testosterone is really important for muscle, isn't it? And yet, and we were also astounded by this research, in spite of that, in essentially chemically castrated men, they were still able to increase muscle mass, which is just, it's a fantastic thing for us as working in the area. So obviously we're interested in how this might be possible. Long story short, we don't know. We don't know how it's possible. There's some different ideas. Perhaps the muscle mass increase still occurs, but not to the same degree that it would have had the androgens like the testosterone been available. The other idea is that perhaps testosterone is not as important as we originally thought, and there's some, it's just a reference to a study that looks at that idea. There are some other mechanisms by which the body is able to activate those satellite cells, and they can do it independently of testosterone. And then the other one is that perhaps the satellite cell proliferation, that growth, operates under what we call a redundancy system, which is a very interesting area of physiology, which is that if one system breaks down, it's kind of what then another system can take over. It's kind of how they operate the space shuttles. They have many, many redundancy systems if one breaks down. Okay? And that's actually modeled off human or animal biology. So maybe satellite cells operate under a similar system, which is interesting. But the key point, of course, is that even if you're on long-term prescription of androgen deprivation therapy, you can still get stronger and you can still increase your muscle mass. Okay. These are the studies looking at specifically functional performance, where they've measured things like muscle strength, muscle endurance, aerobic endurance, walking speed, sit to stand. These measures of how well you can do things. And it's not surprising, just like in people who don't have cancer, people who do have cancer can get substantial increases in functional performance when undertaking resistance training programs. And the quality of life outcomes, and like I said, there are a number of scales and questionnaires that are used to measure these quality of life outcomes. And across all studies, there were meaningful increases in quality of life. And interestingly, they tended to be better or more improved when people undertook group-based exercise. And that's been our experience as well, running group-based exercise. Yes, there's some accountability, there's incentive, but there's that peer support, and it's immensely important. And it's something that I see the patients put a lot of importance on and value, meeting up together twice a week. It's very, very valuable and very important. And what we do tend to find as well is that the men who come and learn and then try and do it independently, they don't succeed as frequently as those who meet together. Okay, so I might just start to summarize. This is a theoretical model, and I guess the main point here is if we look at musculoskeletal fitness as we get older, it's obvious we all are going to get weaker and less able as we get older. The thing is, if you look at how this curve behaves, eventually we will all end up at a point or a threshold below which we have so little musculoskeletal fitness or function that you're kind of in that realm of disability or unable to do things. We'll all get there. What we can change, though, is how quickly we get there. The dark line is theoretically normal aging process. The dotted line there is androgen deprivation therapy, because it accelerates some of these processes. These normal processes of aging are accelerated on this kind of treatment. What it does is it accelerates our downward turn to that point. And it is clear from the evidence that we have so far that doing resistance training, we can slow that. We can't stop it, obviously, but we can slow it. So the evidence is strong. This is the evidence of exercise in cancer, and specifically prostate. The evidence is strong and it's growing. It's a very, very fast-growing area of research. The associated risks of doing even quite intense resistance training are very, very low. It's a very, very safe kind of exercise, provided it's been prescribed properly and appropriately and carefully. And there are special considerations and contraindications, which is why it is really important that the right kinds of people prescribe the exercise for you, and that will be a clinical exercise physiologist. That's what they are trained to do. Okay. So I might just spend the last few minutes explaining the program that we run out of Strathfield's university campus. I'll make you familiar with two pathways that you can access in order to get involved in resistance training. One is called a man plan. Is anyone familiar with the man plan? Okay. Is there a man plan clinic run locally? Is anyone aware of?
It's right opposite Hornsby Hospital in that Palmerston Road.
If you are aware of the man plan, or if you are eligible for it, I would strongly encourage you to give it a go. And that's a good point that John makes as well. Once you learn how to do some of those things, you build up some skills and some confidence, then you can go and join a gym and just start working independently. It's a fantastic thing to do. So the man plan is for patients receiving Leuquin, and then you're eligible for the referral program. It's 10 weeks in duration. It co-funds, so that the pharmaceutical company co-funds 18 supervised exercise sessions. 16. One of them is an initial assessment, and one's a final assessment as well. And then that information gets shared with GPs and specialists. So that's a good program if you are eligible. I think Eligard have started doing, different drug company, they've started doing a similar, offering a similar program as well. Of course, the other pathway that's available to most of you is allied health services through the enhanced primary care plans. So you're eligible for 5 of these a year through Medicare. They can go towards podiatry or physiotherapy or whatever, but it also includes exercise physiology. So if you've never used these before, you would be eligible for a chronic disease management plan. Then this is another way that you can find your way to an exercise program, and it's in part funded by Medicare. All right, there's some of the fine gentlemen in our clinic doing their exercise. And there's one of the groups. That's our 9 o'clock group. They come Mondays and Wednesdays. And yeah. Yeah. He's just a bludger. He just walks around. Yeah, sparking instructions. Look, thank you very much for having me this evening.
Thank you, Tim. Will you take questions?
Absolutely.
I'd just like to ask one with the how did the eligibility to get into your group there? How does that work out?
Okay, so we're quite unique because we don't operate like a business. We're a university clinic, so we're funded by the university to operate, and then our students kind of have a bit of a learning experience through our clinic as well. So the way we work is we get referrals through the MAN plan. When those number of drug company funded sessions expire, our patients, so long as there's still room, our patients are welcome to stay on, and they pay $5 a session. Yeah. And you know, so long as there's still room and we still have capacity and resources to do that, then that's how we'll continue to operate. And the same thing if they come to our clinic through the enhanced primary care referrals. If they get, say, 2 referrals to an exercise physiologist, then we will use those to do a one-on-one initial consultation, and then they can continue the exercise program as long as they wish, and they have a $5 a session fee. So we're quite unique in that sense because we're not.
Seems to me that there should be more of this made available to prostate
cancer. Oh, look,
cancer
it would be fantastic, yeah, and I wish it was the case too. Yeah, but like I said, with the increasing in research, you will see an increase in the number of clinics that pop up locally to support these kinds of programs.
During your presentation, it occurred to me that you were saying that with prostate cancer in men, there's more now today than previously. Would this be due to the fact that most men now are in white-collar type jobs rather than blue-collar? They're not doing the exercise. They're very sedentary in their work habits.
Yes. At risk of speculating, I say I'd agree with that. We can't say that we have any evidence to prove that, and we probably never will, but it's clear from the animal model studies that the exercise is directly interacting with the cancer. And therefore, when the exercise is not there, in other words, you're sedentary, then you're not putting up much resistance to the cancer and doing whatever it wants. So the lack of exercise, it is a factor. It is a factor. There are lots of other factors as well.
Tim, I swim 5 mornings a week. So you're saying can swim and still and should also do resistance training as well?
Absolutely, yes. Swimming.
Swimming's not sufficient.
Swimming is fantastic, but it's not sufficient in so far as making you stronger. I would never stop someone from swimming, but I would encourage someone to also add resistance training. You have to work your muscles to make them stronger.
Hard work in the garden.
As well, I would never discourage someone from doing that. That's also a fantastic
Still
thing.
do resistance training.
Still do it as well.
Even though I swim and I work hard in the garden, I still got to go and do some resistance
That's
training.
right. And now you have a full week.
Oh, I play bowls, but that's not resistance training.
Yes, I guess part of the point is it's a very particular kind of exercise at a particular intensity, and the intensity is quite important. We can do lots of things kind of milling around at low intensity. It's not to say that those things aren't valuable. They're not nearly as valuable as doing something like that is. So you could even consider doing 3 or 4 swimming days and 1 or 2 resistance training days.
Do these fellows lose weight as a result of their resistance training?
Look, that's a question that we need a whole other lecture for. Some do, some don't. Weight by itself is an awful measurement because you hop on the scale and it can't tell you how much of your change in weight has come from increasing muscle and how much has come from decreasing fat. So we're more interested in what we call body composition. So in terms of body composition, it's very obvious to us to just look at someone without doing complex measurements. And we can do complex measurements as well, but you can look at someone like Mick in the middle there, 4 years down the track, and it's very, very obvious what's happened to him in terms
There's
of
no
his body
beer guts there,
composition.
are there?
Yeah. But weight, if you talk about fat, you talk about particularly the fat that aggregates around our midriff, and that's a whole other story, and it's a nutrition story. John.
Tim, I have 2 questions, if I may. Firstly, you focused quite a lot on muscle aspects of your talk. With the Lucrin, I found I had a radical about 3 years ago, and then went on to hormones about 9 months after the radical. So I've had a couple of years on Lucrin. I found the Lucrin, my bone density dropped about 8% during those first couple of years, and at the beginning of the year, I got pretty concerned about the direction of I was going. So I started quite a lot of the man plan and also further gym work. And it was interesting that you're 30% there on the muscle strength. I really think I lost 30%, but I think I've sort of gained 30% or got it back over the last sort of 6 months. Mm. But the second, or first, I'd like a comment on the rehabilitation of the bone aspect.
Itself, yes. And
then secondly, recently I decided to stop the hormone treatment on the basis that I wanted a period where I could get myself a lot fitter. And then when the PSA sort of starts coming back up, I'll go on that for a while and hopefully have a couple of iterations of that way, rather than just sort of a continuous program where I think I'd sort of feel quite degraded. With your specific trialling there, do you look at the different continuous and also intermittent programs and how each person performs on that sort of basis?
Yes, okay. For your first question related to bone, skeletal health, bone mineral density, actually when that slide came up, I meant to mention that there was some evidence for the changes to fat and the changes to muscle, but there's a big hole in terms of the evidence for what happens to bone. So the people who do research in bone, they do usually research in bone in healthy people doing exercise. And when you have healthy people doing exercise, you then find evidence that exercise can sometimes increase bone mineral density. At the very least, it stops bone mineral density losses, which is important as well. In terms of the cancer and especially the effects of the androgen deprivation therapy, we don't have strong evidence to say that doing this type of exercise will increase your bone mineral density or even stop it. We don't know. And that is because bone mineral density is, like most systems in the body, a very strongly, tightly regulated system that has many hormonal impacts or inputs. And the androgen deprivation seems to be particularly damaging to that process. So we're not sure, and many of the patients here have had similar experiences with quite substantial reductions in their bone mineral density. What I could say on that is I would still encourage people to do as much resistance training as they can if they're concerned about bone mineral density, even in the off chance that it's having a positive effect. Theoretically, we think it is. We don't have the strong evidence to prove that. And even without that evidence, I would say start doing it anyway, because there's a good chance that it's helping. It may not even be a measurable effect, or you can't attribute any change to it, but at the very least, if you can slow that rapid rate of loss down, it will be a good thing. Just out of curiosity, did you have that measurement? Did you have a DEXA scan done? Did you have a DEXA for your bone mineral density?
I had one a year after the. I was on a drug trial for Prolia, and they took a bone density one after at the start of the year, and then I had a follow-up one about 2 years later.
Okay.
And there was about 3% difference over that year.
Okay.
But I was on hormone therapy for a year prior to the Prolia trial, so I don't know what the actual baseline was.
Yeah. Was the measurement taken on the same machine?
Yes,
Okay.
same machine.
Okay. Because that often concerns us, where measurements are taken on different machines, and they can actually give quite different numbers. It's something to be aware of. Yeah. So, in terms of your next question, which I'm forgetting,
The second one was with the intermittent strategies.
There are the studies that are done. It's very hard to delve that deep and look at exercise and then split the group further into continuous ADT and intermittent ADT. I can only offer you anecdotal experiences, and some of our patients are continuous and some are intermittent. He wouldn't mind me saying it. Warren in the back over there, he's intermittent for about 7 years, and he always feels a whole lot better when he's off it, and he really he really hates having to go back on it, but he obviously realizes that to control the PSA he has to.
I was just wondering, is there any sort of amount of muscle development that you'd sort of call that's a healthy amount? Like you see these bodybuilder guys and they got muscles everywhere. Does that mean Arnold Schwarzenegger is going to live to be 100? Or because I just don't understand. I think they must get to a stage where it's steroid induced, probably a lot of it.
Yes.
And it'd have to go beyond the stage where it's going to be useful. Is that right or not?
Yes. You are right. I'll start by pointing out that none of us are at risk of looking anything like Arnie. Even if you've exercised 5 days a week or 7 days a week. So that state is, you're correct in saying it's actually quite an unnatural physiological state to be in, and it is induced by steroids. You have to have steroids to kind of look like that.
Yeah.
So it's unnatural. It is a question that interests a lot of people. Obviously, from an athletic perspective, is being a supreme athlete necessarily a healthy thing? Sometimes we murky the water and we think it is, but often when you look into it, it's probably not. So there are some possible negative cardiovascular adaptations that take place. There's some possible negative musculoskeletal adaptations. So no, it's not healthful, it's not necessary, and it's not going to do anything to longevity. By the way, we're not. Our focus is not on longevity so much as the actual quality of the time that we have.
If you don't qualify, say, for the man plan or anything else, and then you want to do the resistance training, and so you go in and roll in a gym, right? Join a gym. Well, how beneficial is that when you're saying it's got to be done at a certain level, certain types of exercises and things like that? Because obviously there are men out there that won't qualify for those type of...
Yes. Look, and that's a real shame. I think situations like that happen sometimes. But if anybody who has prostate cancer would immediately be eligible for the enhanced primary care pathway. It is only 5 sessions annually, but it can give that person an introduction and get them started at least. If you have 2 or 3 sessions with an exercise physiologist, someone who's trained to teach people how to exercise appropriately, then that's a good starting point. And again, you can, from there, go to a gym independently and start working. But what people need is they need those initial skill set, some initial guidance. And unfortunately, you probably won't get that if you just go straight to a gym. If you don't have any option, just go straight to a gym because you're doing something. But you will be missing out a little bit. But if you have cancer, you'll be eligible for that EPC.
What do I have to do to get my husband to do the plan?
Your husband is most welcome.
Is there anything more local than Stratford?
Apparently there's one in Hornsby. What we really need to do, and I don't have this information with me right now, but is get in contact with a network of places that exist more locally. Chatsworth.
I noticed on your slides there, there seem to be two areas where you're focusing: the upper body and the legs. What can you actually do in that sort of core area that?
Perhaps the pictures are misleading. We do a range of exercises that are kind of whole body exercises. So we have, depending on what stage a person is at in terms of their exercise experience, you would usually start with about 10 different kinds of exercises, and then we progress that. And I guess on the whole, everything that needs to be targeted is targeted. So eventually we get men who have more experience doing quite complex lifting, like a deadlift. And a deadlift is a whole body exercise. And we get them to do lots of that because it's a great whole body exercise. So we don't specifically target any area over any other area.
Yep. Just for the benefit of general people, if you get your GP to sign off on a form, you can get membership down at the West Pymble pool. You get the first $200 back from HCF and so forth.
Yes, private health funds have hugely increased their rebates for these kinds. I should have mentioned that, actually. Yeah, private health funds, most private health funds have quite substantial rebates on exercise sessions.